if we're not ready for the ICD-10 transition, if we can't get claims out our door, we can't get money back in. So this is one of those times where we have to really sit and think this through. So what I'm going to talk to you about today is all of the business areas in your practice where you really need to start to think about transitions you need to make. Now, one of the things that I like to try to tell everybody too is please don't believe everything that you read out in the marketplace. This is going to take some strategic planning, but it's not going to cost you $80,000 to implement ICD-10 unless you're starting from scratch. You need a new EMR for some reason. You have nothing in play and you did nothing to prepare. I mean, I'll try to put some of those myths to rest today, but still hopefully stress to you the importance of everything that you need to do to get ready for ICD-10 implementation. So we're going to kind of start and walk our way through some typical areas in a provider's practice. So we have the manager's office. One of the things that you really need to start thinking about right now are your policies and the procedures. Any disease management tracking, trending, PQRS, anything that you have to do with that will all have to be transitioned over to ICD-10. So that's going to require work and a lot of coordination and communication with the health plans you contract, your vendors, and those types of items. So you need to make sure that you really look to that. You have to make sure that you look to your vendors for any system upgrades to make sure that you can actually house both ICD-9 codes and ICD-10 codes. Because keep in mind, ICD-9 is not going away. Our code sets are mandated by HIPAA, and there's certain entities that aren't not covered entities under HIPAA. And workers' comp is under that umbrella. So they are not forced to make the transition to ICD-10. So you have to be able to do dual coding for a long time to come. It'll be state by state, carrier by carrier on who makes the transition over to ICD-10. Because most practice management systems have security features built into them where once you've submitted a claim, there's certain features you can't change. And that usually includes the CPT, HCPC, or diagnosis code. So now you're going to have to find a way to back that claim out, regenerate it, and it's going to mess up your financial reports. So and it takes a lot of staff time. There's going to be a lot of education that's going to be necessary. Basically, every single person in your office is going to require some level of education for ICD-10 implementation, even if it's just awareness to know that the changes are coming in your practice and those types of things. Your information technology, you're going to have to do an assessment and make sure that you have enough server space, if you need any hardware or software upgrades to make the transition. Now, most of us with current billing systems or EMRs have caveats in our maintenance contracts that say any governmental updates are free or any mandates from the government are free. That simply means that they're going to dump those codes into your system for you. It doesn't mean that they'll make it in a workable system. So you need to make sure that you work with your vendors to find out whether or not you need to have any changes made to your systems or how you're going to react to those times. I think we learned a big lesson with 5010, and we did not do enough testing when it came down to that. A lot of that is because our vendors specifically told us they didn't need to test with us. They only wanted to test with a select few and then carry that across the masses, and that failed us significantly. We had some significant payment disruptions under 5010. Whoever your vendor is, your clearinghouse, your practice management, your health plans that you submit directly to, make them test with you. So get ready early, make them test with you, because testing is going to be extremely important to make sure you're getting those codes through and that you can get paid. We don't want to see another 5010 happen to us out in the marketplace. Budgets, especially in smaller practices, my joke is always that sometimes that's whatever happens to be in our checking account at any given time. It's very hard with our decreasing reimbursements every year to actually plan out, but this is one of those times with an implementation this long, and especially if you do need a lot of changes in your practice where you're really going to need to sit and budget out for any system changes, upgrades, those types of things, and training and education, because it's going to be really important as you're moving forward. In the clinical area, you have to take a look around any forms that you're actually using, x-rays, labs, any diagnostics that already have the pre-populated diagnosis codes on there for you so that it's easy to capture for whatever vendor you're using. Those are going to have to be completely revised, which is going to take some training and education. For the most part, those diagnostic codes that are on all of those ordering forms are pretty much going to have to go away. There's no way to expand them and keep them to the same one page that they have. So it's going to take a lot of communication to make sure that you know what to put on those slips when you're ordering so the patients are covered and those types of things. If you have to use advanced beneficiary notices in your practices, those policies will change as they transition to meet the medical necessity with the new I-10 codes. If you use a paper super bill and you put your diagnostic codes on them now, you really have to sit back and think about it, because we've taken the top 50 codes in most specialties under ICD-9 and translated them over to ICD-10. We call them the fast forwards. They're either 2 pages front and back, or they go up to 8 pages front and back. So there's no way for you to put your diagnosis codes on your paper super bills. So, then you have to kind of make a strategic decision, because how are you going to get that information, especially if you have someone doing data entry or charge capture from your super bills or your encounter forms, because you're going to have to make sure that you give them enough information that they can actually put that code on there and pour that information out. So it's going to take a workflow or a process change. So you have to kind of think about those things as you're moving forward. On the provider side, we know that clinical documentation is going to be one of the largest hurdles for ICD-10 implementation. Now, I can tell you that for every single subcategory in ICD-10, there is an unspecified code. There's actually an unspecified code for an unspecified condition. I strongly suggest to you guys, do not latch on those unspecified codes. We just got in writing from a health plan that they will not pay for any unspecified code under ICD-10. That's crazy. There's times we have to use unspecified codes, and we're working to educate them on that. We've heard from other health plans where if you continually use unspecified codes instead of transitioning to the codes that have this level of specificity that you should have in your documentation by then, they're going to start cutting your payments. So you cannot latch onto those unspecified codes. We do what we call ICD-10 documentation readiness assessments. Basically, we just take a look at a provider's medical record and determine whether or not there's enough information documented to transition over to ICD-10. We found that about 65% of the time, there's not enough information. There's new concepts in ICD-10 that you're just not used to documenting. So it's education, and it's working to make sure you capture those concepts as you're moving forward, because you don't want to latch onto those unspecified codes. For billers and coders, ICD-10 has taken the education level higher. So if you have coders in your practice, you really want to make sure that they have a good understanding of anatomy and pathophysiology as you're making the transition forward. You're going to have to learn the new code sets, right? And I tell everybody it's not about the 69,000 codes that we're transitioning to, because it's not the number that should really affect us. It's not the number of codes. It's what's actually found inside the codes that we need to pay attention to. Payer policies are going to change. So if you think about that now, every single local coverage determination or national coverage determination or any other payer policy that you're used to dealing with, all of those are going to have to change and make the transition to ICD-10. We can't react to those internally until the health plans and those begin to do their work on their policies. I can tell you that most of the health plans, the larger ones anyway, are neck deep in this and making the transitions to their policies. Prior authorizations is going to be a big deal, because as we get closer to the implementation date, we've got to work with the health plan to find out whether or not they want you to pre-cert in I-10 or I-9. Those are things that you need to work with your health plans and your vendors as you begin to prepare and move forward with all of those. So patients are going to be confused because they're going to have coverage changes. It's not a benefit plan year for them or the beginning of it. They haven't switched employers, but they will have some type of coverage changes. There's lots of free education that's out there. There's lots of strategic steps that you can actually take. So I'm actually going to take you through some of the potential negative impacts that you're going to see with ICD-10 implementation, and then some solutions as well, so that you can begin to prepare. So let's first talk about productivity. So initially, we know productivity is going to decrease. There's no doubt about it. You see statistics from other countries where they say it took them 2 years to get their productivity up. Well, mostly we hear that from Canada. And the thing of it is they have like 20,000 codes. We have 69,000 codes. We don't use them the same. But here's the real kicker. First of all, ICD-10 is not implemented in every province in Canada. Not everybody there uses it. Secondly, the reason they had those productivity issues was because they transitioned not only to ICD-10, but from a DOS-based system to an EMR-based system at the same time. That's where their productivity issues. Any of you guys that have implemented an EMR, you know what that does to your workflow. That's where your real productivity issues came from. They didn't think it through. It wasn't strategically done. So you can't compare ourselves with any other country. I kind of make the joke that, we're the ones that took our codes to 69,000 with our own clinical modifications, and we're the United States, right? We supersize everything. So why not our code set? So there are issues that you need to really think through. If you have someone that's doing data entry for you, you do your own coding, you have to think about the alphanumeric portion of ICD-10. If they're used to using a keypad, the numeric keypad, that's going to change for them and it's going to slow down because they've got to throw in those characters now. So those are some things that you need to think about. Have them start working early so that they're getting used to that flow and those types of things. New guidelines are going to slow us down, there's no doubt about it. The codes are not exactly the same, obviously, as they were, or there'd be no point in transitioning. So that new language will slow us down as we learn the lookup process and get used to it again. And of course, we're going to have uncertainty as to how to assign a code. There's going to be times and instances when you're working in ICD-10 where you're going to beg for more specificity and think that we should have it because we have so many more codes now, only to find out that there was actually a more specific code in ICD-9 or vice versa. So you will have that slowdown period as you're moving and transitioning over. Interrupted cash flow is a huge risk for all of us. We need to make sure that we work with our health plans early on. We need to make sure that we adapt to their changes in policies and procedures. There's going to be a lot of changes that are going to be hitting us fast come closer to the implementation date, and we need to be nimble enough to react to those and make sure that we have someone in our practice staying on top of them. We've got to look for denials, make sure our systems are working and someone's actually tracking to make sure that both your I-9 claims that were already in your system are getting paid and that your I-10 claims are actually going through the entire process in order to get adjudicated and not lost in the electronic world. So you've really got to make sure that you stay on that so that you can reduce those cash flow issues. Increased denials. Right now we don't know what to expect as we're moving and transitioning forward, but there is the risk that we could see those changes if we don't stay on top of them from our health plans where we're submitting the claim, we don't know that there was a change made, and now we've got to go back and do a lot of resubmissions. So that takes staff time and a lot of research, so you want to make sure that you stay on top of it because otherwise you're going to have either be so far behind on your claims that it's going to slow your revenue down, or you're going to have to bring in additional staff to help with the workloads. So if you prepare for it, you'll begin to move forward. Timely filing limits. I like to make sure that I point this out because this is something that I think is really important for us moving forward. There's a lot of us that have signed contracts with our health plans that only give us 60 days for timely filing limits. If you have a contract in your practice that has a 60-day timely filing, go back to your health plan and ask for an extension of that during ICD-10. You can't implement ICD-10 quickly, no matter what anybody tells you, even if you're in a single doc practice. It's not as simple as opening a code book and moving forward. It takes time to implement ICD-10, so you've got to use it wisely. Mapping, if you're working with a vendor on mapping, choose well. If they only use the GEMS files, you're going to have some serious issues. There's flaws in the GEMS files. And if that concept didn't exist under ICD-9, they won't capture it under ICD-10. And I usually kind of relate this to a practice management conversion. You go from one system to another. A lot of times I see people where they say, well, let's just pull all of the data from our old system and just dump it into our new system. And I always shake my head because inevitably it's garbage in, garbage out. And the same thing will happen with your mapping if you don't do this well. Obviously, you don't need the entire book map. You need your codes. So it's something that you need to do. But you have to go back and make sure that you confirm whatever you do with the code book. So if you're working with a vendor that's offering you an easy solution, make sure you question them on what their end result is on those mappings. Because if you start latching onto those unspecified codes, you're going to have revenue issues moving forward. Risk of audits, we already know health plans are preparing for this moving forward with the risk of audits to be able to flag now with the level of specificity and the granularity. What I like about ICD-10 is if you use it right, you can actually submit your claim and have it adjudicated without having to actually send any additional attachments or sit on the phone to try to get the medications approved or the treatments approved, because you can actually spell it out on your claim form with the level of specificity that's found. They'll be able to data mine a lot better than what they can under ICD-9, but I think that we can actually better support our levels and our services and our procedures by the level of specificity. So our first step in preparing for ICD-10 implementation is really communication. It's going to be so important for us to work with others out in the industry. And I have to tell you, in healthcare, we don't play nice with each other. We really don't. We're busy seeing our patients. We're not worried about if the lab's getting paid or how that's getting taken care of. But this is all going to kind of come together with ICD-10, and we really need to make sure that we communicate with our vendors, with our health plans, with our referral sources to make sure that we get all of the information not only that we need, but that the is needed to take care of the patient and for them to get their services and procedures. Think about prescriptions you write. You're going to have to start thinking at least 6 months ahead of time about offering that level of granularity on the scripts, or you're going to have pharmacies calling you because they're not going to be able to get them approved on refills. I guarantee you're going to be overwhelmed with requests for more information and phone calls all day long as people go to get that information that they need. So I tell everybody, this is one of those times we kind of need to lay aside our differences, work together, find out where we can get the education, and kind of come together to take it seriously. One of the first things that I always suggest when you're getting ready for ICD-10 implementation is to do some type of impact analysis. I liken it to a practice management where you're trying to find out what all is going on in the practice, where you kind of start with the patient, you work and you follow that patient the whole way through your practice to figure out where you might have some bottlenecks or something's maybe changing hands a couple of times or falling through, clear through to claim adjudication. You're going to do that same thing for ICD-10, but you're going to follow a diagnosis code. That way you can see what all systems are impacted, what forms, what procedures, all of those types of things, and you can just kind of follow that through. That will actually give you a good understanding of where you need to begin to build your game plan for ICD-10 implementation. Because there is no really one-size-fits-all. You kind of have to tailor it to your own practice, your own needs, and what you're doing along all of that. So it kind of gives you a clear picture of where you're going to need to go. So you're going to determine any area in your practice that's using an ICD-9 code now. You're going to look to any other departments if you're in facilities or those types of things, get input from everybody to figure out where it actually might touch referrals, pre-certs, prior authorizations. Once you do that, then you're going to start building your action plan, figure out what risks you can take, what you need to do to move forward with ICD-10 implementation. It allows you to then have legitimate conversations with your vendors to see what you actually need to do as you're moving forward with it. The last thing that I want to talk about as you're moving forward too is productivity. So in order to understand productivity, you have to know what the status quo is right now. In provider offices, most of us don't know what our current productivity levels are now. So if you really want to find out what your productivity issues are going to be, figure out how many claims are getting coded, how much is going out the door, and set some standards and some bars to accomplish after ICD-10 implementation. Because the battle's not going to end on October 1st of 2014. This is going to be a continual change for a couple years as that data is collected and as health plans react and as we react to the changes that are coming down through. So in order to make sure that we can get back up to the levels that we were, we have to know what our standards are now. We can't go in after the fact and say, I've lost all my productivity, I can't get anything out, when you don't know what the volume is that was happening before. So that's really important when you're moving down through all of that. I mean, ICD-10 implementation, if you do take those strategic steps, there's easy ways that you can get your education, easy ways that you can move forward. A lot of vendors are reaching out to try and help and try to be a catalyst to move people forward. And I know a lot of health plans are actually out there trying to move everything forward because they're extremely worried about it. Under 5010, when we weren't ready, they allowed the government came back and allowed for submission under either 5010 or 4010, and that really threw a wrench into the health plans. They can't do that under ICD-10. They can't get their systems available to accept both an ICD-9 code and an ICD-10 code. So they're really concerned about providers not being ready, so there's a lot of education and that's out there. Now, if you happen to be an AAPC member, if you have a coder or someone in your office that's an AAPC member, we have our implementation tracker tool, and we put down every single step that you need to follow to become in compliance and the timelines for ICD-10 implementation. And it's right on our website. There's actually downloadable resources, a PowerPoint that you can use to educate, and those types of things. So that is available on our website. For any certified coders or any coders that are certified through AAPC, we do have what we call our ICD-10 proficiency exam. It's required of anybody that holds an AAPC certification. And basically it's a test on ICD-10. It's our way of putting out there in the marketplace that our coders are still the gold seal. They can code under ICD-10, they're proficient, and you'll be okay to hire them, and that they'll be able to take you and move forward with ICD-10 implementation. So we give the 2-year window of opportunity. It's open book, it's online, but that's what our plans are to make sure that moving forward, everybody out in the industry knows that our coders are still the best ones out there and that are actually prepared for this transition.
when does that start?
October 1st of 2013, and then it'll run through September 30th of 2015. We left it open after implementation. If I was an employer, I would insist that my employee take it before implementation, but we did leave it open just in case.
Testing. Obviously, a lot of times we do testing through our clearinghouses, not directly to the provider, the insurance provider. So do you feel that the insurance providers are going to provide a gateway to open that communication so that we'll know that the claims will be tested and properly coded?
I have to tell you, I offend vendors all the time, and it's not my intention to do it. It's my intention to make sure that the providers are protected. They don't want to test because they can't handle the volumes. I say, and I tell everyone, insist that they test with you. You're their client just like everyone else, and if they don't test individually with you, you don't know what's going on. So I tell them, make them test with you, because if you don't, you'll have a 50-10 issue all over again.
Just like the old days, we thought the Big Bertha golf club would make us swing better and hit the ball further. These EMR vendors are trying to make us believe that their systems will make us code better. But in asking these EMR vendors, will we be prepared to use their systems that will give us the proper code? And when we go to bill, they're looking at me and say, we never intended that. You are the coder. You will still have to supply that code that goes into that billing system. And no way can we structure our data to give you the automatic ICD-10 code that you will need. But that's what the selling point has been on these EMRs, as the savior. And Big Bertha never made me
It's a disservice out in the marketplace. I really wish the government would regulate the sales tactics of the vendors. I really do, because it is an issue that's out there. And I'll point out one thing, especially with EMRs. I love EMRs, and I'll tell you, I have a love-hate relationship with them because they can do so much good, but they can cause so much evil. I've actually seen practices that have implemented EMRs, and they've actually had to start coding lower, because what inevitably happens is the physician gets to the end piece where they have to pull in that diagnostic code in order to close out their encounter. They get frustrated. They either don't pick the right code. I actually had a physician pick one time hearing loss unspecified, and under the assessment and plan he wrote no hearing loss. I removed cerumen. He couldn't find the code for cerumen removal, so he put hearing loss. Well, that went out on the claim. You know, it gets frustrating, or else I see where there's no A and P, no assessment and plan after they pick a diagnosis code. You can't support medical necessity if you don't have an assessment and plan. So it's going to come down to you and working internally to build some tools, working with your specialty societies so that they can assist you.
Yet you've already said that the cheat sheet will be 10 pages long.
Well, you can narrow your cheat sheet down, but it will help you. I mean, it's better than holding a 4.5-pound code book.
Yeah, and as far as the different policies and all the DICD codes, we here in a committee with our different carriers, I've asked my medical director, when will these LCD policies be set up with the diagnostic codes? And they said, don't worry about it, we'll take care of that. Well, that's going to expand those ICD diagnostic codes to determine what will be paid and won't be paid. How is that going to be? How is that being taken care of by the private insurance industry or Medicare at this present time?
Both of them. I mean, and for CMS, I know they're working on it, but we see no real work on it. The health plans, I know that they're moving forward, and I can tell you that I've seen it because we've worked with health plans as our clients, where we've helped them transition their policies over. You've got to keep after them. That's the only thing I can tell you, is just stay on top of them and make them accountable to you.
I use the APMA coding resource online.
Yes.
Are you going to have a crosswalk between ICD-9 and ICD-10?
I can tell you that the only place APMA will have that, yes, we're going to have an automatic crosswalk on the Coding Resource Center in the ICD-10 section that will go from ICD-9 to ICD-10 and back.
There's some exceptions to ICD-10, some workers' comp, and isn't this supposed to be an all or nothing thing, and how does that make sense?
Well, so our code sets are mandated by HIPAA, and there's people that aren't considered covered entities under HIPAA, workers' comp, certain liability. So they are not forced to make the transition. There's 3 states, to my knowledge, that have laws on the book that force them. So if you live in Texas, Hawaii, or Minnesota, kudos, you don't have to worry about dual coding. Everybody else, it's going to be state by state, carrier by carrier. So what we found is these larger health plans that have the workers' comp branches, they're making the transition because they're paying the money to do it now anyway. It's going to be those smaller companies that we work with, where it's going to be carrier by carrier, state by state. They don't have to make the transition. There is talks at NCVHS right now on holding them to a higher level of standard that says that, you know what, no, you have to hold yourselves to the same standards as everybody else out in the marketplace. Those workers' comp companies can lobby, though, let me tell you, and fight back, and they don't believe they should be held to the same standards as the rest of us. We actually provided testimony on the nuances and the problems that causes. They're trying to get it to move forward, but you know, anything in the government, it's going to take years to happen.
I saw there's a spring conference for HEMA for computer-assisted coding. That was not touched on at all. Do you mind just discussing what computer-assisted coding is and how that's going to affect I-10?
Yeah, absolutely. Computer-assisted coding is great if you're technology savvy and you like to use those types of things. In order for it to work, you have to really kind of look to the vendor. How did they come up with their solutions and those types of things? Because normally it'll talk you through some questions and get you to the right code. That's a little bit harder to have happen under ICD-10. And what we're finding is that a lot of times in order for, especially for a coder or someone who's using them productively, in order to stay productive, you've got to have two monitors, one that has the computer-assisted software up on one screen and the claims that they're working or their billing system on the other. It's the only way that you can actually manipulate. Otherwise, you're minimizing and expanding. You have to know the right questions to ask in order to get to the right codes. And so if you like that type of thing, you can continue using it, but there are some definite downfalls with coding-assisted software moving forward.
It's my understanding that the Medicare replacement plans are reimbursed or monetarily compensated based upon diagnoses, as diagnosis-driven. That being the case, is it coincidental, or do you see this as being the prototype for down the line for ICD-10, where you alluded to that eventually will be compensated, or providers will be compensated based upon diagnosis codes?
I don't think it's coincidental. I think you see the push towards data. We've seen it. We've seen the push towards audits and information and trying to make sure that we have all of that. So I think that just continues to, you'll see that continue to transition and move us towards that, where we're not paid based solely on the diagnostic information, but it will influence our levels of medical necessity, the levels of service that we bill out, and the payments that we're going to receive back in, because we already have the health plans that are saying, you don't provide us with the specificity, we're going to pay you less in reimbursement. So I think you're going to start seeing some tiered structures in the next 3 or 4 years, where if you're using those codes, then you're going to see lesser reimbursements.
One of the things you didn't touch on was what is your suggested reserves for money come October 1st, 2014? What would you suggest that the doctors try to put aside for working capital? Because we've heard it all across the board, but what would you say?
I mean, I would say to be comfortable, I would try to set aside 2 months worth of income, which is very hard to do. But if you don't have a good, healthy line of credit, you're going to want to make sure that you have enough until everybody gets their feet under them to be able to pay your bills.
Since ICD-10 is standard across the world, essentially, but in fact, not everybody has 7 characters in their ICD-10. That's why we have the CM, and that's the U.S. version of this. First of all, who has 7 other than the U.S.?
No one.
Who has 6
No
other
one.
than U.S.? Are they at 5? Are there people below 5, by the way?
There's people below 5 for the most part. World Health Organization takes most of them to the 5th character.
Okay, but we decided we would go further because one of the characters that I think are doing that, and I'm not sure if other countries are doing it, would be a character for laterality. Do other countries have right and left bunions?
There are codes, certain codes that have laterality built into them, but the answer is overwhelmingly no.
And then the question is, what does laterality, designating a right or a left on an ICD-10 code, have to do with patient care, patient quality, patient improvement, as opposed to the fact that at the very same claim you're going to be putting a laterality on the CPT code, and your medical record, unless you want to go unspecified, will have laterality in that. And it just seems to me that, and I'm editorializing.
You're setting me up here.
I'm setting you up here, and it's not your fault.
Right.
Because actually ICD-10 sounds like a wonderful thing for everybody. The bottom line is that laterality has everything to do with data mining.
Yes.
It has nothing to do with patient care.
Absolutely.
And why did we let that happen?
Well, so, I mean, I can give you my standard simple answer. If you go back to the committee that worked on the clinical modifications for ICD-10, they'll tell you that physicians from every specialty were included and contributed. I can't find the list anywhere. I'm very friendly with most specialty society organizations, and I've made the phone calls. Who was it? And no one can tell you. I'd like to see that level of transparency because I'd like to see who did contribute. As for the laterality, to me, it makes sense that you have it documented in the medical record because obviously I should be able to tell someone if it was the right side or the left side or whatever. As to taking it to a coding standpoint, I get what you're saying with the modifier. Unfortunately, though, some payers don't allow the use of right or left as a modifier, and they only want the 50. So, you know, some of those instances, so there's going to be those gray areas. So I could fight you back a little bit on it, but it's important for documentation. Is it important enough to pull it out in the coding? I don't know. I can't. You got me on a fence on that one.
Actually,
So-
Rhonda, too, could you explain to the folks in the room, they may not know what WEDI is.
Absolutely.
Just spend a minute.
So WEDI is the Work Group for Electronic Data Interchange, and it's a group you can actually join for free, but they put out information, and basically people in the industry actually come out and work together. So I serve on some committees that are on with ICD-10 implementation. It's a great way to collaborate and be able to have a little bit more power because CMS also looks to WEDI for some initiatives and those types of things. Changes that there's flaws in the book. There's no doubt about it. You'll find certain things, and like my biggest sticking point right now, and we were talking about it earlier, is under ICD-10 for injury coding. There's codes for the place of occurrence, the activity of the patient, and their work status, which we could gripe about why use all of that information, but then I can tell you don't have to submit all of your paper attachments and all of that kind of information. Plus, you don't even know what carriers are going to accept that level of coding right now because most of them don't accept E-codes. So it's this, anyway, there's an unspecified code for activity, location, or work status. But then there's a guideline that says if you don't know, don't use the unspecified code. So why give me an unspecified code and then give me a guideline to tell me not to use it? So you'll find flaws like that we're working, and these guys are actually working on. We're working on them at AAPC and through WEDI and those types of things where we want to get this type of stuff addressed. The problem is the book's in the draft format right now, and we're in a code set freeze, which means unless it's a new or emergent disease process or something, they won't make the changes right now. So we think maybe we've gotten a change made, or there might be, but we won't know until 2014. And so unfortunately, what that means is that if you find a mistake or an error and you get it addressed, if you have no assurance that it's going to change, you can't educate towards the change. You can tell people that it might be coming or that there might be a change that you need to think of, but it's going to be an issue moving forward.
The simple one for us was sesamoiditis indexing to osteomyelitis. And that was a pretty easiest, obvious thing for us that it's wrong. And we brought that to their attention, but
yeah, you would think an index issue they would fix, and that's not a coding issue. That's just a simple index. It's wrong in the index. But to get them to change it, you can't do it. So we try, and that's why I've been trying to put a lot of our work through WEDI because the weight of the group behind it has a little bit more.
And so when would the closest final version we could start working on be available?
The closest version that you can work on right now is the one that's out right now because it's under the code set freeze.
I know you can buy that one. You think that's going to be close enough?
It has to be close enough. It's what we have to use because the other one won't be out until after implementation.
And you can get that. You can get the database for free on the CMS site. Just Google.
Yeah.
Google it.
Don't
Well, by the way,
don't print.
before you get into your question, just to let you know, because one of the common questions we get with the Coding Resource Center, because obviously we have ICD-9 on that, we have Coding Resource Center on a development site right now with ICD-9 and ICD-10, and that's where we're putting together the crosswalks and things like that for you. It's a big issue as to when would we actually release it with an ICD-10 look, because if we do it too much in advance, trust me, there will be some practices that some staff person is going to start coding ICD-10 now, and they're going to find, obviously, it's going to get kicked right back against.
Yeah, I understand that they're also working on ICD-11, and that's pretty close down the road as well. Is that true?
So the draft format will be released in 2015, and would have to go through our clinical modification piece, which if you go back in history, we've been talking about ICD-10 since like, what, 1996, 97, whatever. I actually even taught a course of it in it back in 2002 when we really thought it was coming in. You know, there's no way. It would take us another decade to get our clinical modifications, and then we'd have all of the issues that we're still having around now. Plus, ICD-11 is built for computer systems, and a lot of doctors aren't using EMRs. They're not using electronics right now. So it kind of takes that piece out of it. So it's not something that we could just jump past ICD-10 and jump into it, because it would be another 10 or 15 years before we make the change. And whatever we don't like about ICD-10, I can really make a case for you guys that we need to move past ICD-9. Every time we submit a claim to a carrier, we're red flagging ourselves because we have to use unspecified codes or codes with little specificity for our higher level services. Then we've got to prove our records and prove our services, and we can't do that now without sending everything in, which puts us in a risk for an audit.